Okay, so in this section, we're going to talk about administering chemo medications. And the first and most important thing you need to know is that you should not be administering these unless you are a chemo certified nurse, and that is for your safety and for the patient safety. So what are some of the things you need to know about administering these meds? Most chemo drugs are vesicants and cause severe tissue damage, and so extravasation is really important. We need to really pay attention, make sure that there is a good blood return. Chemo's often, or it's preferred to give them through a central line or port for that reason, and because a larger vessel allows for better dilution to decrease the vascular damage. There's a risk of anaphylaxis with several types of several chemo meds. So we need to be observing for anaphylaxis. Nausea and vomiting is extremely common with most chemo meds. The most effective medications for those are ones that are serotonin antagonists like ondansetron. The antiemetic should be administered before the chemo begins. Cold, bland foods with not much odor may be the best tolerated, but basically, cancer nurses will tell you if the patient thinks something will work, they're probably going to try to get something into them. Understand that there are late effects of most chemo treatments, and so someone may develop complications down the road. That can be things like a secondary malignancy, cardiomyopathy, or cognitive, neurologic, or psychologic complications. Blood transfusions are commonly needed in cancer care. So we're going to talk for just a little bit about blood transfusions. Whole blood can be administered or individual components may be transfused. And the most common one that you've seen will be packed red blood cells. So when a blood transfusion is given for anemia, they usually don't give whole blood. They give just the red blood cells. They take out the other parts to give to other patients. Fresh frozen plasma may be given. Platelets may be given. White blood cells actually can be given by transfusion, but it's less common. Vital signs need to be monitored prior to administration, 15 minutes after initiation, hourly during that transfusion, and on completion. At administering the blood transfusion, you need to check the ID of the recipient with the donor's group and type. It is a two-person check. Okay, when you go and check the blood out of the blood bank, you check with the blood bank worker, and then when you go to the unit, two nurses have to check the blood and make sure it's being administered to the correct person and that it matches type. The first 50 milliliters or 20% of that transfusion should be administered slowly with continuous observation. So someone needs to be at bedside. And a lot of you have probably gotten the opportunity to be that blood babysitter. So the nurse can do something else and someone's observing. A blood filter is used to eliminate particles and prevent that blood from precipitating and clumping up. Blood needs to be hung within 30 minutes of arrival from the blood bank. It must be completed within 4 hours or discontinued because of the risk of infection. If it has to be given more slowly, then units can be divided and part of a unit can be kept refrigerated until it's needed. Blood can be administered only with normal saline. We're going to talk about types of reactions in just a minute, but the steps, if you suspect a reaction, are for pretty much any type. If you suspect a reaction, you stop the transfusion, you get a set of vital signs, maintain IV access with normal saline and new tubing. You notify the practitioner. Don't restart until they're evaluated by that provider. And the remainder of that unit, bag, and the tubing all get sent to lab. Now, let's talk about the types of reactions. A hemolytic is the scary one, or the most severe one. It's caused by an incompatible blood type. So what happens is antigens cause hemolysis. They cause red blood cell breakdown. So if the antibodies attach to antigens and cause red blood cell breakdown. So if there's an incompatible blood type transfused, they're going to break down all the red blood cells. Okay, it's the most common cause of death related to transfusions. It can cause DIC, which we talked about earlier, and it can cause kidney failure. You might see a patient complain of, I just don't feel right. They complain of low back pain. They may have some vital sign changes. Their blood pressure decreases, their heart rate increases, things like that. Okay, they may start to run an elevated temperature with a hemolytic. Febrile reaction. This is a patient who maybe has had multiple transfusions and they may have antibodies against these white blood cells, and it can cause chills, tachycardia, fever, hypotension, and tachypnea. So they try to prevent this if a patient has a lot of antibodies by matching blood, giving blood from a single donor that's well matched, or trying to give leukocyte poor blood. They try to remove as many leukocytes as possible. For mild reactions or someone who's at risk for this, they may pre-medicate with Tylenol. Allergic reactions can happen in patients who, they're more likely to happen in patients who have other allergies. And this is going to look like itching, urticaria is itching, bronchospasm, anaphylaxis. It's typically a response to leukocytes. And so they would give leukocyte poor or washed red blood cells. If a patient is at risk for this, or if they have had mild reactions, they may get Benadryl or diphenhydramine prior to transfusion. Bacterial or septic blood reaction is when the blood product is contaminated. Think about this as instant sepsis. So they suddenly develop fever, tachycardia, hypotension, chill, shock. That's what sepsis looks like. Circulatory overload is due to excess volume. So we're giving this transfusion, but if the patient can't handle the volume, they can go into heart failure. Okay, circulatory overload. Fluid overload. So that may look like dyspnea, hypoxia, crackles, hypertension, bounding pulse, restlessness, confusion. This often is treated with, but more often we see preventive for this with diuretics before or between units. This is why you've seen that order for furosemide before blood transfusion or between those units. Okay. That's all for hematologic. Good luck. Again, break it down, take your time going through each disease process.